It's a pleasure to welcome you back to the American College of Surgeons Bulletin Brief from the Frontline Surgeon Voices. And with me today is a return guest and longtime friend, Dr. Heidi Nelson, the director of the American College of Surgeons Cancer Programs. Welcome, Dr. Nelson.
Thank you, Dr. Wexler. Great to be back.
Always a pleasure to have you here with us. Today, we're going to pick your brain a little bit about some specific issues that arose within COVID-19 these last 18 or so months, and specifically a loss of screening opportunities where patients would have gone for mammography, colonoscopy, chest x-rays, skin checks, whatever it happens to be, prostate exams, PSAs. People didn't go for screening because they were told not to go. Offices were closed, visits became virtual. And I wanted to get your perspective about this problem and what the ACS Cancer Programs is doing to try to catch up with that gap in screening.
Yeah, thanks so much. It's a very important topic. Obviously, we've launched a national quality improvement program to try to address it to the best of our ability. Now, ordinarily, we take for granted that people get screening and that's how we're going to control as best possible the burden of cancer in the U.S., as well as other treatments for those who do have cancer. But it's been a large strategy to reduce the risk of cancer through screening. And so, when we heard Dr. Ned Sharpless speak at the 2020 Congress last year about the projected increase in deaths from cancer, it was kind of an eye-opening experience for me. I was sitting in the audience thinking, this is serious. He projected at least 10,000 more breast and colorectal deaths. And then, we continued in COVID and didn't think a lot about what to do about it. And then an article came out by Dr. Chen and colleagues actually demonstrating the deficit that occurred in screening from February through June of last year, and showed that 9 million people, based on ICD codes, missed their screening. And you can think, well, if you didn't get a mammogram 1 year, you'll just get the next. But in fact, only 60% of women who are eligible to get screened actually get screening. So those who don't get it every year are going to miss yet another year and are going to come in with advanced disease. It is a really important prevention, if you were, way of preventing more cancer. So the American Cancer Society had already launched a campaign about screening. And when we saw the numbers, the deficit, we decided to join forces with them and use their messaging, their toolkits, and their evidence-based interventions, and coupling that with our accredited programs and our standards to launch a national quality improvement project. So a bit unprecedented, but it's moving along, and I think it's going to have an impact.
Well, it sounds like a much needed impact. And from that number of 9 million, are there any data yet on how many cancers have appeared and any stage migration?
It's too early to tell. Now, we have put into place the rapid cancer reporting system, which gives us the opportunity to look at real-time data a little bit more. We just launched that in 2020, and we're trying to replace the call for data, which used to give us older data, so we can get concurrent data that's almost real-time. And so we are trying to take a look at that information. But we do know that based on the enrollment targets for this National Quality Improvement Project, that if everybody reached their targets, for getting screening done in more patients, we may be able to add 70,000 additional screenings each month. That's our hope. It's not going to close 9 million, but if we can make an impact, that would be fantastic.
Now, the mathematical modeling is always a bit of a sticky wicket, always a bit tricky. So is that modeling assuming that everybody is fully operational? In other words, the capacity for those 70,000 additional screening exams, does that assume that in all areas, in all 50 states, everyone is up to par, or is it impacted by what's going on with COVID? So you read, for example, Idaho was the most recent I read, where there are no beds anywhere. Before that, it was Texas, and it was Florida, it was the Southeast. How is that equation impacted?
Great question. It's hard for us to know all of that in detail right now. We're working with programs to help them resolve barriers and take down barriers. And we host webinars with the Cancer Society to sort of address some of those things and find out from participants what they've been able to implement, such as extended hours for mammograms and things like that. I think the kinds of activities for screening that are easier are the ones involving radiology, so mammography and CT for lung screening, whereas more invasive procedures like colonoscopy, even maybe pap smears, may be more difficult when people's resources are all diverted to the urgency of COVID in states such as Idaho. So I'm sure we're going to see variation across the country in how people perform in their programs based on the surge locally.
Yeah, I mean, because it's interesting, you've got the 9 million, but I wonder the number doesn't go up as a result of continued surges and continued hospital beds being full and procedures not being done as a result of it. So tell us a little bit about the partnership, the strategic partnership with the American Cancer Society. You said this particular initiative was unprecedented, but so was the COVID pandemic. But we do work with the American Cancer Society a lot, and maybe you can tell us, is there precedent for some other joint programs with the American Cancer Society?
Our relationship with the American Cancer Society goes back to our respective origins. So, I mean, we basically came out of the same general concept, and they have a slightly different mission and agenda than we do. I mean, we're all out to help cancer patients. But they've been a long time collaborative force with us through helping with the National Cancer Database, the American Joint Committee on Cancer for the staging standards. I mean, they're really just a powerful organization, and we're delighted that we're working with them. And I think this is going to actually bring us even closer together, because we're working closely with them to really understand what works out in the field and what doesn't work. And where we're resourced with these programs who can do the implementation and get credit for standards, they have a lot of research in this field. And so it's a perfect relationship and collaborative arrangement. And I think it's going to mean that we'll see more of these efforts in the future, where we decide to tackle something, whether it's disparities or smoking or tobacco cessation. I think there are ample opportunities going forward for us to bring together our unique strengths towards reducing the cancer burden in the United States.
So what's the message for the fellows of the college and the members? What can we do to help achieve the mission of this joint initiative between the ACS and the ACS?
Right. No, thank you for asking that question. I think what's really important is anything that a fellow of the college can do to speak with those who are doing the screening work or overseeing the screening and encourage more screening where it's feasible, that would be wonderful, because the more the boots on the ground folks who are doing the screening work understand the real importance and impact it's going to have, is helpful. And the outpatient activities hopefully are not as impacted by the COVID surges, which are more ICU inpatient. So maybe some of these things can go on. So we just have to up the awareness. So any of you out there who can do that locally, it would be greatly appreciated. Thank you.
Well, fantastic. It's an important initiative. The number of 9 million is staggering. And as I say, it may potentially be greater as time goes on and the real math is done. And then I think what's really going to hit home is when we hear about the cancers and how the stage of cancers in 2022 was different than it was in 2019 in areas for which cancers are detected by screening as opposed to symptoms. Perhaps you could give us a few words about the specifics of the PDSA.
Right. So the PDSA is actually on the website, and anybody can download it and use it as a tool to both figure out what their screening used to be before the pandemic came to the shores of the United States. And then they can figure out what their target goal should be to try to close the gap and reduce the deficit from last year. And it's really has all the interventions you might imagine that are evidence-based. So you have a list to choose from, and then you can monitor monthly your progress. So it's readily available, and your institution should feel free to use it should you wish to. We hope you will.
And for those viewers and listeners not familiar with the term PDSA.
The PDSA stands for Plan, Do, Study, Act.
Thank you. I'd like to give you the opportunity to share any additional thoughts or reflections you might have before we close.
I think I would just say that I'm impressed that the machinery and the infrastructure and the cultural readiness of the Commission on Cancer and the National Accreditation Program for Breast Centers was really how we were able to draft the PDSA Quality Improvement Project in 3 weeks, roll it out to programs and give them 6 weeks to sign up, and are doing this over the course of 6 months. We haven't done anything quite like this before. So it's just, to me, a remarkable signature of how impactful these programs really are, because they're on the ready. It's sort of like a National Guard, if you will, who can be called into action to do things like this. And maybe in the future, we'll see more of this, hopefully not because we have any more pandemics, but just because we have the opportunity to make a large difference in problems that we face.
So speaking of seeing, we'll obviously provide the link for our viewers to look at that work so they can see the specifics of what was developed in the time frame of 6 weeks. Well, I thank you very much, as always, for your inspirational leadership and your words of wisdom with us today, and urge our fellows to take to heart what they've heard from you about helping us get over the other side of this very unfortunate absence and lack of screening during COVID.
Grateful as always for the opportunity to share our stories, and anything that the fellows can do to help their institutions prevent these unnecessary deaths would be wonderful. Thanks so much.
Thanks, Heidi.